All right. That's a thought. So going back to natural family planning, this is kind of that calendar method. Marquette method is just a fancy word for where you use those ovulation predictors, the ones you see in the store that you pee on and it tells you, if you're ovulating or not. Just a fancy word for it. So again, there's lots of different types of barrier methods. All barrier methods really should be used with a spermicide. When you're talking about things like condoms, though, those are the best in the sense of they will also help prevent STIs. Diaphragms and sponges, because they are internal barrier methods, they're not going to provide any STI protection because you're still having skin-to-skin contact. But they can help with pregnancy by blocking the cervix. As you see, you insert it up against the cervix and then remove it at least how long after intercourse? 6 hours. Very good. And then we just show that picture. So when we're talking about this is where that ACE acronym is listed. So I told you about those. So abdominal pain, chest pain, headaches, eye problems, which is talking about the double vision or the blurred vision, and then either severe leg pain or slurred speech. Those can both be signs of blood clots. So any of those symptoms that could lead you to think of blood clots, because that's the biggest complication of oral contraceptives with estrogen, is blood clots. Now, progestin only doesn't have these increased risk of blood clots. So women who are over 35 that are smokers, that's a safer option for them. So this is that intrauterine device or IUD I was telling you about. So as you see, it looks kind of like a T shape. It sits up inside the uterus, and they are not that big, so it does not fit the uterus quite that as much. But it helps by not only releasing hormones over a period of several years, but it also creates a blockage so that if you have a fertilized egg that comes down, it doesn't have the ability as well to attach to the uterus. I'm sure y'all seen pictures. There was a big one that was floating on Facebook a couple years ago where it showed a baby holding the IUD in their hand. I have a feeling that was either photoshopped or planned, where they took the IUD and put it in the baby's hand, but it can happen. Babies can be born with IUDs implanted into their body because they basically grow around the IUD. It does happen. It is a risk, but IUDs are pretty effective. We talked a lot about Plan B. So again, there's 3 main types: a prescription pill, a non-prescription pill that you get from the pharmacist, and then a copper IUD. And those have to be used within 72 hours in order to be effective, because after 72 hours, you're probably implanted by then, and they're not going to do anything once the egg has implanted. So we talked about permanent contraception, which is your sterilization. 2 big things to teach patients about sterilization. One, it is not 100% effective. Sometimes people think that once they're sterilized that there is no chance that they're going to get pregnant, and that's just not the case. Now, it's very effective. It's at like 99.98, whatever it is, effective. But there is always that chance, especially soon after the procedures happen. I've heard of people getting pregnant years later after having this done. So it's a small risk, but it is a risk. And again, there's 2 ways they do it in the female. Either they'll cut and tie off the fallopian tubes, or they can put a coil in the fallopian tube to cause scar tissue. Same thing with the vasectomy. They cut the ends and tie the ends. But it does take a little bit of time before it's fully effective. Another thing that's important to teach patients is that whole STI talk. So we talked about that your condoms are the only method that's effective for STI. So if they get this done and they are not in a monogamous relationship, having still that conversation about transmission risk is important. And that's with anybody. So abortion. We're going to talk about spontaneous abortion next week. Spontaneous abortion is an unintentional loss of a pregnancy, like a miscarriage. In the OB world, any loss of pregnancy before 20 weeks is called an abortion. So sometimes people hear abortion and they think intentional abortion, and it could have been a miscarriage. But here we're talking about intentional abortion. How long you can wait to get an abortion varies from state to state. I think Virginia is not 20 weeks. I want to say it's like 16 weeks, but it's earlier than that. And sometimes it's done just for whatever needs they have. Sometimes it's for physical reasons. And they can be done medically, so very early pregnancies, they can take medication. They'll take methotrexate, which actually kills the fetus, and then they'll take something called misoprostol, which actually pushes it out. We'll talk about misoprostol a lot when we get to postpartum, because misoprostol we use to help with postpartum hemorrhage as well, but they'll use that to kind of expel the fetus. Or they'll do surgical abortions, which is basically like a D&C. They go in, they scrape the uterus and suck out the fetus, and the one that's very graphic that they like to show on TV. So let's do some practice questions. I mentioned practice questions. So let's analyze and talk about some of these NCLEX questions. So a physician prescribes clomiphene citrate for a woman experiencing infertility. She's very concerned about her risk of multiple births. So the nurse's most appropriate response would be what? So A is, this is a legitimate concern. Would you like to discuss this further before your treatment begins? What do you think? Is that reasonable to say? Yeah, that sounds pretty good. So we'll see if there's one better. B, no one has ever had more than triplets with Clomid. Is that what you're going? No. For one, wrong. For two, even triplets to me would be that's too many. So it's still a concern. Exactly. And you're still not validating the patient's concern. So a big thing with therapeutic communication, even if you had, and when you take NCLEX or even when you're doing proctored exams, sometimes even if you don't know the answer to the question, if you start reading this, you're like, I don't have a clue what clomiphene is. Oh my God, I'm screwed. Not necessarily, because sometimes questions are not really asking you, say specifically about the drug. In this case, it could be any drug, but what we're really focusing on is therapeutic communication. And that's a big thing NCLEX loves, is therapeutic communication. Anytime you discount the patient's feelings, you push that away, you don't validate their concerns, you're not trying to help them, then those are going to be wrong answers. So B is basically just overlooking their concerns like it's not important. Whatever. If you get triplets, it's all right. C, ovulation will be monitored with ultrasound, so this will not happen. What y'all think? Impossible. So you can do an ultrasound and look at the ovary and see, oh yes, we can see that you recently ovulated because the corpus, it'll be empty, and but you can't actually sit there and watch the egg coming out and being ovulated. So no, false. Even if you could, what are you going to do? Just sit there and watch? Oh, look, it looks like you are going to have multiples. 10% is a very low risk, so you don't need to worry too much. Couple things wrong with this. One, it discounts their feelings. It's basically blowing off their feelings, which we never want to do. And anytime you see the words "don't worry," those are always wrong answers. We never tell patients "don't worry." We never give them false hope. So "don't worry" is a phrase that NCLEX likes to throw in that you should see it and be like, nope, I'm steering away from that one. So going back to A, that is our best answer. This is a legitimate concern. You're validating that patient's concern. You're saying, yes, I see this is a problem for you, which means I need to take care of it. Would you like to discuss this further before your treatment begins? You're offering help. You're finding a way for them to get more information before they are presented with this procedure. So in this case, this question really isn't asking about clomiphene. It's really looking at therapeutic communication. So another one, a nurse in a clinic is reviewing contraceptive use with a group of adolescent clients. Which of the following statement reflects an understanding of the teaching? A water-soluble lubricant should be used with condoms. Is this correct? What do y'all think? Let's see. Let's see if B, C, or D sounds better. So a diaphragm should be removed 2 hours after intercourse. Is that correct? No, it's 6 hours. So we know B is wrong, so we can take that one away. Oral contraceptives can worsen cases of acne. What do y'all think? Nope. No, it doesn't. Sometimes we will even prescribe oral contraceptives for acne. The way that the hormones react, they actually will oftentimes improve acne cases. So this would be wrong because we actually use oral contraceptives to improve acne. And a contraceptive patch is replaced once a month. Is this correct? No. How often? Once a week. Very good. We leave it off for a week. So that takes us back to A. A is our correct answer. So a lot of times people don't think of using a lubricant with condoms because condoms are pre-lubricated. It's not where you have to apply additional lubricants. But condoms that are, and there are some that are non-lubricated, for example, like lambskin and all that stuff, because of the way they interact, that do have to be lubricated in addition to being applied. But most condoms that people see are pre-lubricated, but if you don't have some kind of lubricant, friction is going to break down the latex, causing micro tears, and then you're going to be welcoming a baby in 9 months. So a nurse in a clinic is teaching a client about medroxyprogesterone, aka Depo-Provera. Which of the following information should the nurse include? Y'all's favorite kind of questions? Select all that apply. So, weight loss can occur. Exactly. So that one wouldn't be correct. You are protected against STIs. Nope. It does not protect against STIs, so that one's incorrect. You should increase your intake of calcium. Yes, very good. So medroxyprogesterone decreases your bone density, and usually they don't recommend that you're on this more than a couple of years for that reason, continuously, because it can decrease your bone density and make your bones brittle. So for patients that are on this, it is recommended that they use a calcium vitamin D combo supplement to decrease that loss of bone. You should avoid taking antibiotics. Not with this one. So with oral contraceptives that you take by mouth, and there's twofold to this. It is affected by antibiotics, but not medroxyprogesterone. You can take all the antibiotics you want, and it ain't going to interfere because it's given by IM. But another thing, even if this was oral contraceptives, it's not that you have to avoid taking antibiotics. It's that you have to be cautious and use a backup method to prevent pregnancy. It's not where the two drugs are going to interact and cause a problem. It's just not going to make your birth control effective. So you don't have to avoid antibiotics, just making sure that you have a backup plan. And then irregular vaginal spotting can occur. Is that true? It is true, especially when it's first inserted, or not inserted, first injected. It can cause vaginal spotting. It's normal. Even when they've been on it for a while, sometimes they'll have like breakthrough spotting, and that's totally fine. So your two answers here were increasing your intake of calcium as well as vaginal spotting can occur. So a nurse is caring for a client diagnosed with gonorrhea. What medication are we going to anticipate being prescribed? Very good. A, ceftriaxone. So in addition to what drug as well? Yes, azithromycin and ceftriaxone. That is what we give for gonorrhea. What do we give fluconazole for? Yes, yeast. Very good. So your candida or your yeast infections, we use fluconazole. Now, what do we use metronidazole for? Yep, that's flagell. So that's the one you're going to use for BV and trichomonas or bacterial vaginosis. So the metronidazole is your flagell, and we will use that for bacterial vaginosis and trichomonas. Now, Sudovanine, anybody know what drug that is? It's okay. I wouldn't. It's a specialized drug. It's actually a drug for HIV. We didn't talk about that one, but not everybody has seen that one before because there's a lot of HIV drugs. What? Oh, did she talk about that one? Oh, I'm telling. I understand. A nurse in an OB clinic is reinforcing teaching with a client about using an IUD for contraception. Which of the following statements by the client indicates understanding? So, an IUD should be replaced annually during pelvic exam. Is that true? No. It's usually either 5 years or 10 years, depending on the brand, but definitely not every year. That would be obnoxious. I cannot get an IUD until after I've had a child. Is that true? It's not true. Now, a lot of OBs recommend that you not get an IUD until after you've had a child because the cervix is more open, so they're easier to insert, but it is not contraindicated. People that need them before that, they can certainly get them. They're just a little more difficult to insert. So it is more pushed and recommended after you've had a child, but it's not to say you can't have it. I should expect intermittent abdominal pain while the IUD is in place. What do you think? No, you shouldn't expect it. So if it said in the first couple days, then yeah, that would be okay. Because in the first couple days, you may have some cramping as your body's getting used to that being there. But intermittent means it comes and goes while you have it, and that's not normal. So our only answer that's left is a change in the string length of my IUD is not expected. That is true. We teach patients when they have an intrauterine device that you saw on the picture where you got two strings, they look kind of like fishing line. They hang down in the vagina, and what patients are supposed to do is check the string length once a month. At the same time, I'm sure all of you do your breast exams, right? Check your string length, and it should feel relatively in the same place it was before. If you can't find the strings or if it feels like it's migrated, you should get it checked by the provider because it could mean that it's trying to migrate out or even up. So they're expected to check the strings. I doubt a lot of people do, and some people say they can never find them. That sometimes providers, because the strings are really long and then they cut them based on the length of your vagina. So sometimes providers will cut them super short and you can't even find them. And that is the end of my slideshow. Any questions? Let me turn this light back on. So again, next week we'll be doing pregnancy, all things pregnancy, and it is a lot of information. Make sure you listen to the pre-recorded pregnancy lectures before class, because when we talk about abnormalities with pregnancy, it's not going to make sense if you don't know the basic normal stuff. So make sure y'all listen to those. I have the links posted in week 2 content, but it's also, if you found my YouTube page, it's on there. There is a worksheet posted under week 2 content. It's optional. It is for your own use if you find it helpful. It is not required, and we'll talk about the results in tutoring next week if you come to tutoring. It's a worksheet just to use as you're listening to the recorded lectures as well as when you're reading, just to reinforce some of that information. Again, it's optional. It's not required, but it is an additional resource for you to use. Any questions? And then your homework for next week is that safe dosage. Hopefully y'all have all done it already though, because you did it to prepare for your dosage count. But make sure y'all get all these things uploaded, especially the clinical stuff before you start clinical. So we have that there. The rest of the stuff, it's not due today, it's due next week. But just as a reminder to get those done. If y'all have any questions, I'm gonna let y'all go. And I will see y'all. Are any of y'all with me on Saturday, or are y'all all Friday people? Y'all are Friday people. So enjoy your clinical tomorrow. Let me know if you have any questions, and I will see y'all next week.